that point of time. She was also a known hypertensive for 20 years on medications, and she had a significant obstetric history in the form of 2 first trimester abortions. She also had 1 second trimester pregnancy loss with preeclampsia. So summarizing, this is a middle-aged lady who had presented with abdominal pain, vomiting, some constitutional symptoms, history of headache and delusion in the past, and bad obstetric history. So coming to the examination, this patient had elevation of blood pressure in all 4 limbs. However, there was no asymmetry. All the peripheral pulses were well felt, no bruit. She had pallor. She had some posterior cervical lymphadenopathy, which was firm, discrete, and non-tender. Her fundus examination was normal, ENT examination was normal, and systemic examination was unremarkable. So let's go to the initial investigations. So hemogram, she had a microcytic hypochromic anemia, and rest of the hemogram was normal. Her renal function tests were mildly deranged, probably because of dehydration due to vomiting. And LFT, what was important is mildly elevated alkaline phosphatase and GGT. Her acute phase response was ESR was 15, CRP was mildly elevated, the unit is milligram per liter, so the normal value is less than 6. So she had come to us with outside CT abdomen reports, and it was showing an aortic stenosis at the junction of thoracic and abdominal aorta, and this was extending for 3 centimeters. So it was basically a long segment stenosis. There was also associated wall thickening of the descending thoracic aorta, and also wall thickening at the origin of celiac artery with luminal narrowing. In addition to these vascular findings, what was important is she had multiple enlarged abdominal and thoracic lymph nodes, and they were seen in all regions: the paratracheal, subcarinal, paraesophageal, periportal, and para-aortic. The maximum diameter of these lesions nodes were 20 mm. So what we are dealing with is, as per the semantics, we are dealing with a case of mid-aortic syndrome. So what is mid-aortic syndrome? It's nothing but a segmental narrowing of the descending thoracic and or the abdominal aorta. So as such, mid-aortic syndrome can be congenital or acquired. The acquired causes, we will look into it in the subsequent slides. So a little further into the evaluation, ANA was positive, 2+ speckle by IIF. However, all her sub-serologies were negative. IgG4 levels were also done because there was significant involvement of the abdominal part of the aorta. IgG4 levels were elevated, 2517. ACE levels were normal. LDH was mildly elevated, 514, but uric acid levels were normal. In view of the poor obstetric outcomes, antiphospholipid antibodies was done, and all 5 antibodies, the LA, beta-2-GP1, anticardiolipin, annexins, and PSPT were significantly elevated. Further on, we proceeded with a lymph node biopsy because she had significant lymphadenopathy even in the imaging and also clinically. A posterior cervical lymph node biopsy was done because that was more accessible, and that showed subcapsular and paracortical areas composed of foamy macrophages, histiocytosis, and plasmacytosis. AFP stains were negative, so it was reported as a possible reactive follicular hyperplasia. So because till now we had localized that something is happening in the vasculature, we wanted to get a clear picture. So we proceeded with an MR angio, and as you can see, 2 important findings. One is the first picture where you can see there is a tight stenosis at the junction of the descending thoracic and the abdominal aorta, and in the second picture, if you can see, there is a stenosis at the origin of the celiac artery. In view of the intermittent headache and the loss of consciousness, we also did an MRI of the brain, and that showed scattered foci of flare hyperintensities in the deep white matter and also in the subcortical white matter. So this was labeled as a possible chronic ischemic foci. So at this point of time, with this clinical history and the relevant investigations, we narrowed our diagnosis to 3 things: whether we are dealing with a case of APS with a APS vasculopathy, or we are dealing with 2 different diseases, APS along with Takayasu arthritis, or third, we are dealing with IgG4 related aortitis. So one step further, we went ahead with a PET CT to look up into the vasculature, And what we found interesting was there was no vascular uptake. However, the lymph nodes which we had initially seen in the CT abdomen was also there, and that was picking up in the PET. So now, whether this could be an IgG4 disease, there are few points which are strongly in favor and few points not in favor of IgG4 disease. One thing is the elevated levels of IgG4, generalized lymphadenopathy. These are the two strong points in favor of IgG4. However, the characteristic histopathology was not available. Now, I want to remind the audience that this is a case which was, the biopsy was done in 2012, and at that point of time, the IgG4 disease had just come, and even in the biopsy, we had not done the IgG4 staining. Additionally, there was no extranodal IgG4 disease, and as we know, IgG4 levels can be non-specific and can be elevated in various other rheumatic conditions. Absence of significant periaortitis, which is one important feature in IgG4 disease, was not present in this patient. So, slightly deviating from the topic, I thought I'll just mention why it's difficult to pick up a IgG4 lymphadenopathy is because the characteristic findings of obliterative phlebitis and storiform fibrosis may not be seen in all subtypes of histopathology, and only one subtype, the pseudotumor-like presentation, histologically can have storiform fibrosis. So IgG4 lymphadenopathy can be a mimicker. It can present with like a multicentric Castleman disease, like it could be just a reactive follicular hyperplasia like in our condition, interfollicular expansion, or PTGC variant. So can the aortic involvement be IgG4 related disease? So usually IgG4 related disease aortic involvement happens in elderly males. Our patient was fairly younger and a female patient, and like I already highlighted in the previous slide, presence of significant periaortitis rules towards an IgG4, and our patients did not have that. Severe stenosis has also been less likely reported in a IgG4 disease. So this is a paper which has looked into the various patterns of the vascular territory involvement, and what we can see that in the abdominal aorta, IgG4 disease mainly involves the infrarenal abdominal aorta. Our patient had predominantly a suprarenal disease. So this is the same paper which highlights the elderly age of presentation. So at this point of time, can we conclude that this patient does not have IgG4 disease? So one thing is, we don't have the biopsy findings. So at least with the negative points, we can fairly rule out that IgG4 disease will come less in the cards. So we are left with two possibilities, whether we are dealing with an APS vasculopathy or we are dealing with APS with Takayasu arthritis. So can this be a Takayasu arthritis? The points strongly in favor of that is severely stenotic lesion and osteal involvement of celiac artery. However, the points not in favor of Takayasu arthritis are the normal inflammatory markers and lack of uptake in the PET-CT. However, the argument still holds good if someone has to argue that it could be a fibrotic phase, and that's why the PET-CT has not picked up, which is fairly true. Now, what are the points in favor of an APS? Strongly positive APS antibodies on repeated occasions, recurrent first and second trimester abortions, and chronic ischemic foci in the brain. So does it fulfill the criteria for APS? Definitely yes. We have an evidence of small vessel thrombosis, obstetric mortality, poor obstetric outcomes, and we have antibody positivity. So is there an association between APS antibodies and Takayasu arthritis? So the first demonstration of this association was given none other than by Mishra sir way back in 1994, where he had this case was published in Lancet, and 41% of patients of Takayasu arthritis had IgG anticardiolipin antibodies, and 5 of them had high titers, that's moderate to high titers of anticardiolipin antibodies. So subsequently in 2015, this was one more series of 8 patients where there was an association shown between APS and Takayasu arthritis. Now, what is the mechanism behind arterial stenosis in APS? So to put it short, APL antibodies can cause the stimulation of monocytes, platelets, and endothelial cells, and this can lead to endothelial cell activation. So this further triggers the mTOR pathway, and mTOR pathway is implicated in an APS vasculopathy. Additionally, APL antibodies can cause foam cell formation, which contributes to atherosclerosis, and also APS antibodies can directly cause the complement activation, trigger a coagulation cascade, and that can contribute to vasculopathy. So, can renal artery and the celiac artery be involved in APS? In our patient, renal artery was not involved, but just an extra source of information. So, in this study, what they found was 26% of the patients with APL antibodies had renal artery stenosis, and the involvement was in the proximal 1/3. Celiac artery stenosis has also been well defined in a series of 17 patients. So this was a study of 17 patients with predominant secondary APS, and these lesions in the celiac artery were at the ostium or just distal to it, and they were smooth and regular. So now that we have looked into the renal and the celiac, can aortic involvement also be explained due to APS? So this was a study which has reported 4 cases where aortic involvement per se was there, and one of the case had severe aortic involvement. Now, so what did we do for this patient? Because of this dilemma of whether it's an APS or APS with Takarasu, patient was started on treatment with steroids with 0.5 mg per kg, anticoagulation because she definitely fulfilled the criteria for APS, and in view of uncontrolled hypertension, stenting of the abdominal aorta was done. And these were the pressures before the stenting and after the stenting. There was significant reduction in the pressure. Now, we also gave 2 doses of rituximab at that point of time, although this could be slightly debatable. The reason for giving rituximab was mainly we thought APL antibodies are contributing to the vasculopathy, and because there is a pathomechanistic role, rituximab was given to the patient. So this was in 2011-12, and after that we have 8-year follow-up of the patient. So 2011 was the initial presentation. In 2012, patient underwent the stenting with rituximab. I'm sorry for the typo, it's 2013, where the patient had 1 year follow-up and disease parameters were stable. And lastly, we saw the patient in 2020, where repeat imaging was stable and patients did not recruit any new arterial territories, and inflammatory markers were also normal. So conclusion, I am sorry if I have caused you this, but the arguments can be on either side, whether we want to call it as APS or whether we want to call it as APS with Takaisu, both are good. But if I had to choose one, considering all the points I had mentioned and considering the long follow-up we had without any new areas of involvement, I would put my bet more on APS. Thank you.
She was asking whether she needs to invite me. Well, who among you think it is Takaisu alone with presence of antiphospholipid antibody? Please raise your hand. No, Takaisu primarily and the presence of antiphospholipid antibody. Who among you feel that it is all this is APLA? Raise your hand. I'm not going to ask you why you think so. Right, good. You've asked me for my comments. Honestly, I feel that the angiographic finding that you suggested, that goes more with Takaisu. I have not seen an APLA with such extensive stenotic lesions. And the fact that there was, after stent, the BP reduces, these are not the features of APLA. But surely she had presence of not only anti-cardiolipin antibodies, anti-beta 2 GP1, and she had a bad obstructive history in the sense that beyond 12 weeks there was a pregnancy vestige. But these, you know, these are all classification criteria. If you want to fit in there, it fits in. But at bedside, I think she was more Takayasu than APLA. You don't agree? And the fact that to give rituximab, steroid, was like a trigger-happy immunologist. I wouldn't be doing so, but I'm not criticizing you. We sometimes have to make decisions at bedside without very firm, but the fact that the inflammatory markers were negative, that is not a point at all for against Takayasu. If Takayasu have come to you and as an obstructive phase, but if I were to vote for one, I would say that given the pathological abnormality as documented by angiography, look to me Takayasu. Yes, he has serological profile. If she were to go in for another pregnancy, maybe anticoagulation was justified, but not immunosuppression. There is no role for immunosuppression to treat the antibodies. Have you done the antibodies again after a gap of 6 weeks?
Yes, sir. The antibodies were repeated.
So serologically is confirmed. Antiphospholipid antibodies, the spectrum has been widened, various other vascular manifestations has been noticed. But I am a little bit old timer. You know, my study was 94 or something. That time I was trying to look at anticardiolipin antibody, abstained by infection, anything. So Savitri Srivastav, one of a great cardiologist, friend of Madam Naik, she's kind of the pediatric rheumatologist of repute, we must remember that. She asked me, if you think cardiolipin can be targeted, why don't you look at Takayasu? So she gave cases, and at the department we were doing in-house assays, so we published it. The study was published in Lancet. In the same month, the New England Journal of Medicine had the Massachusetts case record and referred to our finding that antiphospholipid antibody would have obstructive abnormalities like in Takayasu. There was a case. I don't think this is IgG4 disease anyway. You made very valid ground. Don't go by the serum IgG4 level. That is a very, very soft point for the diagnosis. You need the biopsy, the storiform fibrosis, and the plasma cells within the lymph node to have IgG4, which is very difficult to document. Rohini, you can.
I just had a comment about the anticoagulation as well, that since it's predominantly arterial, whether we could have used only aspirin or a combination of aspirin and clopidogrel.
And regarding the narrowing, I have a pediatric patient with antiphospholipid who also had Ivan syndrome, who has very long segment narrowings of femoral artery. So, I mean, it's possible. However, this tight stenosis seems more in favor of Takayasu.
We can have.
Can we have questions and comments, please?
Any comments or any thoughts?
My question is to Dr. Shivraj. Sir, how long were the steroids given?
It was just given for a very short, like the regular 0.5 mg per kg.
And so in
for a month and then
2013,
tapered and stopped.
2013 and 20, she was completely off.
Yeah, she was completely off immunosuppression. So
and what about anticoagulation?
Anticoagulation was continued.
Till 2020.
Yes, yes.
So, in Dr. Mishra's own words, I wouldn't jail you for giving, that's what he used to tell us in rounds, if you give. I think I would give a bit of immunosuppression, maybe not rituximab, Because Takayasu, the problem is you are not able to say whether the disease is active or not. Not infrequently, it is actually active intravascularly, and we are not able to pick up those with markers. And we've seen reversal of stenosis as a sign of, as an outcome of improvement in Takayasu. Now we know that. My question was, what is the evidence for Redux in Takayasu when people have used? I know it's not recommended, but if people have used, is there? And this is interesting because after that, the patient has been fine for all these years till 2019. So that's a follow-up up to 6 years, and not on any immunosuppression now. So that's very interesting. So is there any data? I'm sure there is.
So the rituximab was mainly given keeping in mind APS.
That I know, but what is the data on Takayasu?
Yeah, there are few studies of rituximab in Takayasu. However, they have not been showing positive reports. It's maybe 50% benefit. That's all.
I have a question from Mishra sir. So what?
Come to the mic.
So what was the reason that you found high prevalence of ACL in your earlier paper, 1994 papers?
We were in the discovery mode. In the discovery mode, you don't try to find out logic. You want to see whether you can, it's a vascular event in Takayasu, and we don't know whether there was microthrombi initiating the progress of narrowing, platelet thrombi, or inside the wall inflammation. So basically, since it is an extensive disease, we thought whether there was a circulating pathogenic trigger, and therefore we did. I mean, you must congratulate us. That's how discoveries are done. You have to look new pathways, like they are now looking at TGF molecule, which are the molecules within the vascular biology, those who are working, whether there is excess of fibrogenic potential. So we looked at that angle. It was a pure chance of 40%, and therefore Lancet accepted it.
Yes.
And I got my promotion.
Fixing the result before.
Huh?
Fixing the result before.
Yeah.
Discovery is to be done.
Yeah.
Good, very good.
I have one small question. Dr. Shivraj, you have done 3 therapeutic interventions in the patient, given immunosuppression, given anticoagulation, and done stenting. What benefited the patient most, do you feel, right now, like because 10 years have passed?
So 10 years apart, the patient is asymptomatic, blood pressures are under control, requires only, I think, minimum dose of only single antihypertension, and has not recruited any new involvement of the involvement in the vascular territory.
So do you think the stenting helped more than immunosuppression and anticoagulation?
So one thing in stenting is, even in cases of Takayasu arthritis also, if you stent, there's always a concern about an instant restenosis.
Yeah, that's
Now,
what.
for
So
that
because
reason,
the patient has not restenosed, so it is likely that it is a one-time process which has just been sorted out and it has not come back again. Because usually APS and
I think I have to interrupt this in oration at 12 o'clock. So we have to move on with the presentation. We started late here though, but can you?
Yeah. So we move on.
So next session will be on pitfalls in 2022 classification criteria of vasculitic disorders by Dr. Chikashi Tarao from Japan. Over to you.
Okay, thank you. So, hi, I'm Chikashi Tarao. Today I'd like to talk about the pitfalls in 2022 classification criteria of vasculitic disorders. And as you know, in 2022, EULA and the HCR together co-announced the Nobel classification criterion of the GPA and MPA and EGPA. And I believe that this is a great step toward precision medicine and also the good treatment and management for the patient with ANCA-associated vasculitis. And based on their literatures, it said that these are around 5 to 6 years efforts of the many experts. And importantly, these criteria were pieced together based on the same data set analyzed. So they emphasize that these are classification criteria for the small and medium vessel vasculitis. So this is not a diagnostic criteria. And it might be notable that recently the HCR or EULA came to avoid to establish the diagnostic criteria. So, for example, for the rheumatoid arthritis, it was classification criteria, not diagnostic criteria. And this was also true to the IgG-related disease in 2014 or 15, I don't remember well, but the Japanese group released the diagnostic criteria of IgG-related disease. However, now the latest one is the classification criteria. And also, they emphasize to exclude the possibility of diseases mimicking small or medium vessel vasculitis, since this is a classification criteria. And most additional important point is this criteria includes the items not likely the disease, so not simply the adding the scores, but we can decrease the scores. So I summarize here the 3 important pitfalls. So again, do not use these to diagnose the disease, just for the classification. And do exclude vasculitis mimics in prior. And do know comparators. So since you are the all experts and the rheumatologists, so it would be useful to learn how these criteria were made and also what kind of data sets the experts analyzed. So it would be useful to know the other small or medium vessel vasculitis than the ANCA-associated vasculitis, including the glioglobulinic vasculitis or polyarteritis nodosa, or non-ANCA-associated small vessel vasculitis that could not be subtyped, and Behçet disease, and IgA vasculitis, and primary central nervous system vasculitis, and anti-GBM disease. So, in other words, in addition to the other form of the ANCA-associated vasculitis, we can use this criterion to classify what the diseases are, the patients are suffering from. And also, in prior, we have to exclude the possibility of the vasculitis mimics. Saying what are the vasculitis mimics? So, as you know, the major mimics are the infection or tumor, and it also it includes other types of the vascular mimics, including the vasculopathies, cholesterol emboli, or thrombotic and hypercoagulative conditions, and hypereosinophilic syndrome, and eosinophilic malignancies. So this flowchart indicates how the experts came to this criterion. So it comprises of a total of 5 different stages. So the stage 1 is the kind of the discovery mode, as Ramos says. So this is the picking up the possible items which would be useful to classify the patients among the medium or small vessel vasculitis. And then, based on this information, they made a case report form called DC-VAS case report form. and it contains more than 1,000 clinical laboratory or pathology and imaging data elements. Then they distributed this form into the many experts worldwide and asked them to fulfill, asked them to register the patients they are seeing or they saw within the recent 6 months. Are highly suspected of having a small or medium-sized vasculitis. And the stage 3 and 4 are kind of the QC steps. For stage 3 are filtering steps for the items, and stage 4 are filtering steps of the patients. So stage 3, they took some statistical approach and also based on the frequency-based approach. And it might be notable that they excluded very rare manifestations which showed up among the patients with some 5%. So it means that if some regional patients have the very unique presentations, this item does not show up in the classification criteria. And for the QC steps for the subjects, so the committee requires at least 2 experts' agreement of the diagnosis. So then they came to this number, 2,072 cases, and found 91 candidate items, and they constructed the final models and using the 2 different datasets. First is this derivation dataset, and the second is validation dataset. Importantly, these 3 ANCA-associated vasculitis datasets are using almost the same dataset in this final matrix for the 272 patients by the 91 candidate items. And while the experts are living worldwide, however, this was not true for the patients. And as you can see here, the majority of the subjects are Europeans. And also, when we focus on the how many patients are registered per site, in also the European sites registered more samples than the other regions, indicating that not only in the number of the total sites, but also the fraction of the patients, the final data sets are dominated by the European samples. And regarding the experts, this was more distributed worldwide, and also the 6 Italian, 20 Japanese and 6 Indian experts were included in the experts who contribute to establish diagnostic classification criteria. And it would be useful to know what kind of disease are included, and also how many diseases are included in the comparators. I mean that the sensitivity and specificity is against the comparison between the target disease and the other diseases. So when we take the EGPA as an example, the sensitivity and specificity was computed by the diseases other than the EGPA among the data set. And so this slide indicates that what kind of diseases are included in the data set. And importantly, these other forms of vasculitis include the diseases I previously shared with you. And also, to take the example of the EGPA, this classification criteria is useful to distinguish EGPA patients from the MPA or GPA. So, there are several points to note. So no region-specific items show up in this classification criterion. So if you are quite confident that the Indian patients have this unique characteristics, then you can develop or add the item into compute the sensitivity and specificity by their own and then get published. And also the representations excluded, and this classification criteria is best balanced criteria, so not complex separation, indicating that if you found the borderline patients with the scores, then since you are expert, you can think that while this patient doesn't fulfill the classification criterion, I'm quite confident that this patient suffers from the GPA or EGPA. So for the EGPA, it would be notable that the P anchor or MPO anchor are not included in the items. So you can see here, here. So of course, in comparison with the healthy controls, P anchor would be quite useful to find the patient with EGPA. However, in this data set, the certain fraction or number of the patients of the NPA are included. So in total, in this data set, NPO anchor or P anchor are not that useful to distinguish EGPA from the controls. And the characteristic feature is here, the blood eosinophil counts. And this item has the 5 scores, and so the threshold is 6 scores. So if you found just one of the clinical features among the 3 items, in addition to the increase of the eosinophil counts, then you can classify the EGPA. And also, this classification criteria showed a very good AUC in the sensitivity and specificity. And these results I put here are the results of the validation dataset. So, of course, when we apply the classification criteria onto the derivation dataset, it easily results in the overfitting. So, these results are free from the overfitting. Regarding the NPA, so in contrast to the EGPA, the P anchor and NPO anchor are critical items, and so here, here. So even in the comparison with the controls, including the EGPA, since the NPA patients have the quite high chance to be positive for the anchor or NPO anchor, so this item only has as high score as 6. So if you find a patient with NPO anchor positive, and if you don't have the subjects carrying these items with the negative values, you can classify the patient as NPA. Again, this classification criteria has a very good AUC in sensitivity and specificity in the validation dataset. So regarding the criteria for the GPA, the point here is that the C anchor and the PR3 anchor are critical items because as you can see here, there's around 70% of the patients are positive for GPA. However, for the controls, less than the 3% are positive. And again, these controls include the MPA or EGPA and other kind of the vasculitis, so not the healthy controls. Still, this C anchor PR3 anchor has critically important meaning to classify the patient as a GPA. And again, this classification criteria has very good AUC and sensitivity and specificity in the validation dataset. So, since these 3 classification criteria are listed together, so one item have the high score in a single disease can have the negative score in the other criteria. And so there are the quite limited number of the items to be noted. Just for the laboratory exams, eosinophil counter is important and anchor things are very important, and there are the limited number of the items to be noted. And the physical exam, there are the critical organs to be affected by the anchor-associated vasculitis. So it's not very hard to memorize these classification criteria. So as conclusions, 2022 classification criteria have high sensitivity, specificity, and AUC to distinguish each of EGPA, MPA, and GPA from comparators, but we cannot use these criteria for the diagnosis. And regional differences, their manifestations, and prior should be taken into consideration in daily practice. Thank you for listening.
Thanks for sticking to the time. I think we'll skip the questions because of the time constraint. Or we can have one question. One quick question, please.
What is the importance of differentiating vagus from jockstrap, that is PR3 from MPO, except the epidemiological point of view? Is there any difference in treatment?
Oh yeah, it's very interesting question. Yeah, as far as you are just use the corticosteroids, for example, there are maybe no meaning to distinguish the one disease from the others. However, another viewpoint of the the patients, it would be quite important to get the accurate diagnosis because each of the diseases have a bit different prognosis and also different complications and different organs to be affected.
Remission and relapses are different in both the conditions.
No, without pinpoint differentiation, I can start the treatment. What I want to do.
EGPA would be different.
The last talk would be on zero steroid regimen in the management of vasculitis and consensus. I invite Dr. Archana Sonawale, Professor and Head of the Unit, Department of Medicine Rheumatology Services, SAFE GMC, Mumbai, and for giving the controversies. And question and answer session will be headed by Dr. Rohini Samant, Consultant Rheumatologist, PD Indija Hospital, Mumbai. Good afternoon, everybody. I have been given the task of speaking about zero steroid management of patients with vasculitis. Now, we all know that steroids are both a friend and a foe in management of most of the rheumatic diseases, and especially in case of ANCA-associated vasculitis, they are a mainstay of the management, but reducing the dose of these steroids is a significant unmet need for most of our patients. And managing patients of ANCA-associated vasculitis and also other vasculitis without using steroids is practically impossible, especially in the induction phase. Also, the clarity on the dose and the duration still eludes us largely, and the various toxic effects of the steroids, we are all aware of them, and this is a issue which needs to be addressed over here. Several studies have been done which measure the ANCA-associated, in patients of ANCA-associated vasculitis, the high cumulative dose of steroids that we are administering leads to worse glucocorticoid-related toxicity, and this has prompted us to use a lot of steroid-sparing agents. The recent ACR guidelines have also mentioned that because of the previous data on several studies like LOAS and PEXIVAS have indicated that reduced steroid dose is equally efficacious and maybe less toxic. This has prompted ACR 21 guidelines to recommend the use of reduced steroid regimes in ANCA-associated vasculitis, along with the various steroid-sparing agents like rituximab and cyclophosphamide. So what exactly do you mean by a low-dose protocol? When you say low-dose protocol, the Vasculitis Foundation and ACR 21 mentions that you can give the initial pulse glucocorticoid in the same dose, as that is around 500 milligrams to 1 gram of methylprednisolone, which we give intravenously for either 1 to 3 days to begin with. And in the first week, the dose will be in the range of 1 mg per kg of oral prednisolone. However, in the reduced dose protocol, from the week 2 itself, the dose will be reduced to 50% of the initial dose, as seen over here, and then the tapering will be relatively faster as compared to the standard dose regime, so that you reach a dose of up to 5 to 7.5 milligrams over the 14th to the 15th week, and after that it will be depending on the treating physician's choice whether it's to make it completely zero. So the LOAS trial is the first trial which I would like to mention over here, which is a landmark trial which was conducted in Japan, and here around 140 patients who had mild ANCA-associated vasculitis. They did not have any severe glomerulonephritis or alveolar hemorrhages. These patients were taken up, and they were randomized to receive either reduced dose, which was in the dose of around 0.5 mg per kg to begin with, and half of 70 patients were randomized to receive the high dose, that is 1 mg per kg per day of steroids, and both the groups received rituximab in 4 doses. The results showed that the primary outcome, which was indicated by a BVAS score of 0 and the reduction in the dose of the steroids to at least less than 10 mg at the end of 26 weeks. This primary endpoint was achieved in 71% of the patients in the reduced dose regimen and 69.2% of the patients in the standard dose regimen, indicating that the reduced dose regimen is non-inferior to the high dose glucocorticoids if rituximab is given along with in induction of disease remission. Also, the serious adverse events and the rate of infection was found to be lower in the patients with the reduced dose regimen, and obviously the long-term glucocorticoid side effects which you see like dyslipidemia, diabetes and insomnia, etc. were much lower in the reduced dose regime. Then we have the famous FEXIVAS trial, which was conducted in UK, in which 704 patients with severe glomerulonephritis or pulmonary alveolar hemorrhages. So these patients were severe ANCA-associated vasculitis. They were randomized in a ratio of 1:1:1:1. So now amongst these patients, the patients either received plasma exchange or they did not receive plasma exchange, and they received standard dose glucocorticoids or they received low dose glucocorticoids. So 4 such groups were there, and these patients were studied over the next 6 months. Now the dose of glucocorticoid was reduced, and almost it was reduced to 60%. The exposure of glucocorticoid was reduced to was almost 60% less in the reduced dose group as compared to the standard dose group. And it was seen that the endpoint of either all-cause mortality or death or the occurrence of end-stage renal disease was much lower in the patients with the reduced dose protocol. Now, plasma exchange did not show any benefit, and there was no difference due to plasma exchange in either reaching the primary endpoint of death or occurrence of ESRD in both the groups. And at the end of 1 year, the occurrence of infections was much less in the reduced dose group. The serious adverse events were, however, same in both the reduced dose and the standard dose group. This was a very important trial which prompted making guidelines for reduction of the dose of glucocorticoids in ANCA-associated vasculitis. Now, next we have the Avacopan, which is the new kid on the block. It is a C5a receptor antagonist which is being promoted to kind of replace steroids as a very promising drug in ANCA-associated vasculitis. Here we have a study which shows that it is a randomized control trial where 331 patients with newly diagnosed or relapsing mild ANCA-associated vasculitis were randomized to receive Avacopan in the dose of 30 milligrams BD. And Avacopan was given over a period of 52 weeks. The other group received steroids at 60 milligrams to begin with, but the steroid dose was tapered, and by the end of 20 weeks, these patients were made off steroids. 0 steroid was given to the patients. And the primary endpoint was remission at 26 weeks and no steroids being given to the patients for at least 4 weeks prior to the 26-week remission period date, and the BVAS score of 0. The secondary endpoint was that they have to sustain the remission without the use of steroids even at 52 weeks. Avacopan proved to be non-inferior to prednisolone in sustenance, in occurrence of remission, and it also proved superior to prednisolone in sustaining remission. There are some caveats in this study which I will talk about at the end. This study needs a special mention because here there are only 11 patients which have been studied over here, but this is the only study which we found in our in this literature search where absolutely no steroids have been given to patients, even though the patients had severe ANCA-associated vasculitis. This was published in Nephrology, Dialysis and Transplant. These patients, 6 of them had granulomatosis with polyangiitis and 5 had microscopic polyangiitis. They were PR3 or MPO positive, and all the patients were either given rituximab in the induction of remission, and 5 out of these patients were given cyclophosphamide in addition to rituximab. Absolutely no intravenous or oral glucocorticoid was given to these patients. All the 11 patients achieved remission at the end of 6 months, and this was indicated by a fall in the CRP and also by improvement in the renal function in the patients. One of the patients had a serious adverse event of community acquired pneumonia, and 1 patient had relapse. Now, all these patients were elderly, they were above 80, and advanced age, frailty, and also the higher risk of occurrence of serious infections and cardiovascular mortality is what had prompted the investigators to give absolutely no steroids in this patient, and still it proved beneficial to give rituximab and cyclophosphamide and manage these patients. Now here is one study which indicates that even maintenance without steroids can be achieved. This was a study by Pepper et al. Conducted in UK and Ireland, where both MPO and PR3 vasculitis and a few of ANCA-negative possible glomerulonephritis patients were taken, and they were treated with rituximab in the dose of 1 gram for 2 doses, and this was followed by cyclophosphamide in pulse dose at 0, 2, 4, 6 and 8 and 10 weeks. Now steroids were given only in the form of pulse, and after 1 pulse, the one group was given only 1 week of steroid in the dose of 0.5 mg per kg, and the other group was given 14 days of steroids. That's it. And after this, the steroids were completely omitted, and the patients were given maintenance with either azathioprine, mycophenolate mofetil, or methotrexate or rituximab. So it was 49 patients were studied. There were 2 different cohorts, and 23 in the group 1. They were divided into 2 groups, but these 2 groups were not really compared with each other. What was the difference in the 2 groups was that in one group only serious patients with glomerulonephritis and ANCA-associated and pulmonary alveolar hemorrhages were also included. All patients achieved remission, and there was a observed decrease in the creatinine, proteinuria, CRP, ANCA levels, and the VIVAS. Now these patients were actually being compared with the various UVAS trial, like the and also the rituximab trial. Those were the patients who were given high dose glucocorticoids, and comparison with the age and sex match controlled and patients in the UVAS and the rituximab trial was done, and it was found that giving low dose glucocorticoids was equally effective in not only the induction but also the maintenance of remission in these patients. Now, what are the limitations? All these studies look very promising, but definitely all of them have some limitations. For example, all these studies, the first study, that is the LOVAS, this was done in much older patients. They were all only MPO positive, so we wouldn't know what happened to what would happen if PR3 positive patients were included and given this kind of regime. And they did not have very severe renal dysfunction. So applicability to patients with severe renal dysfunction, PR3 positivity, and in non-Japanese population is unclear. The PEXIVA study was a very strong study. There were not many limitations except that it was an open-label study, and so there could have been some bias in measuring the endpoints, and in also some crossover related bias could have been there. The ADVOCATE study had a lot of limitations, I feel. In this advocate study, patients with very mild renal dysfunction were taken. Now, also it was seen that many of the patients had been given a washout, but not all the patients who were in the avacopan group were completely steroid free. Also with avacopan in India, the availability, the cost and also the lack of knowledge regarding the long-term side effects are a few problems that we pose with avacopan.
Archana, I have to interrupt you. I think there is it's from the organizers that there is a narration going on in the Menon Hall, and so we have to finish fast. I think I'll just take 2 minutes and we'll conclude this session, and we will not take questions for this session.
Okay, so over to Dr. Rohini Madam for a consensus.
So I'll just go with some key messages. I think zero steroid sounds very dramatic, but most of the studies that she has presented talk about less steroids in maintenance. Most of the studies have used steroids for induction, but the dose of steroids has been low in the LOVA study as well as in the Plexiva study. In this landmark study from UK also, they used this for induction. In one study which was very dramatic, there were for 11 patients, elderly patients, no steroids have been used. However, none of them had alveolar hemorrhage or any significant lung involvement. So I would say that using a low dose steroid has been shown to be efficacious, less side effects. However, for maintenance, it seems that we still need, for induction, we still need to use steroids. Maintenance could be steroid free, as has been shown in the study from UK. Avacopan, I think it's a relatively soft study because they did use steroids for induction, and later on followed up with no steroids for maintenance, but again mild vasculitis was studied. So my message would be that perhaps for induction we still need steroids in select cases, particularly alveolar hemorrhage, very severe renal disease, but maybe we could do with low or maybe no steroids in the maintenance phase of the disease. And we still have to work on this, it's a work in progress. Thank you. I think we should all move to the hall, that is what the directive from the organizer is. Thank you.